Okay. Good evening. My name is Prabhath. I'm an acting consultant in family physician. I'm based at Base Hospital, Panadura. On behalf of the Sri Lanka College of Family Physicians, I welcome you, all of you, today to one of our latest episodes in guideline-based clinical scenario discussions conducted by the family medicine registrars. We usually select a topic based on our clinical practice, where we do certain interesting topics that we come across during our consultations. We convert it to a learning activity. And we have two objectives in these presentations. And one of them is to familiarize ourselves with the guidelines pertaining to the topic that is being discussed. And then also to discuss certain practical aspects, challenges, and compromises we may have to consider when following those guidelines in our local settings. So today's presenter is none other than somebody who is very familiar to us, Dr. Prabhath Nanayakkara. He's a registrar in family medicine who is doing his clinical appointments with us in Panadura these days. He had selected a very timely topic, I feel, and it is one of my personal favorites as well. Usually these clinical discussions are led by our president, Dr. Malkanthi Galhena. She will be joining us today a little late. In the meantime, we will start the presentation and proceed. So it's over to you, Prabhath.
Thank you very much, madam, for those kind words of introduction. And actually, you were the person who guided me to do this presentation, because this is not an actual case. It's a simulated case discussion we had regarding smoking cessation. So this is a case of Mr. Pereira, a 42-year-old male who is willing to quit smoking and asks for a help. Before going into the details of the case, now we have several occasions where we come across with smoking cessation. It may be a simplest form of smoking cessation, where we just ask, are you currently smoking? And we just say, if you are smoking, have you thought of stopping, like that? One or two words, we just educate the person during some other consultation. This is in WHO, this is defined as brief intervention or very brief intervention. And also there may be some cases where we need to spend 1 to 3 minutes, like the Australian guidelines describe a case of ask, advice, and help. A small structure to follow, where we can ask just whether the person is currently smoking or not. If not, have you smoked in the past? If it is also not, we can congratulate and reaffirm to stay as a non-smoker. And if answer is yes, we can advise him to stop. So these kind of several interventions are there. For example, there is a 3 to 5 minute consultation, like brief clinical intervention. So now in this consultation, we have a patient who is arriving to us asking for smoking cessation advice. So we have to do a full consultation regarding smoking cessation. So it's a little bit hard task. Like a usual consultation, there is breathing, building up of rapport, empathy, and motivation. Then we follow a format called ask, assess, advise, assist, and arrange. This is the format I will go through in this presentation when presenting the case. So ask what we have to ask. Mr. Pereira started smoking at the age of 20 years. And initially he smoked 1 to 2 cigarettes per week, but gradually frequency increased. For the last 15 years, he is smoking 10 to 12 cigarettes per day. And I asked about the current habit. He smokes his first cigarette of the day in the washroom just after awakening. He tries to avoid smoking inside home as much as possible because of his kids and the pregnant wife. But there are some strong urges like early morning one. He smokes with his friends at the gatherings and especially at weekends while having alcohol. And he smokes 7 to 8 cigarettes during office hours. He takes small breaks. It doesn't affect his office work much. And he can't stop smoking to get on with clients because he's a person involved in marketing field. So I asked, why are you smoking? What happens when you not smoke? Smoking is helpful to relieve his stress, according to him. And he smokes more in stressful situations. So he feels a sense of incompleteness without a cigarette. And also he feels a little bit irritable when his usual cigarette delays. And I asked whether he has tried any other substances. He has tried cannabis, but not using it now regularly. Last instance was a few years back. He has not used any other substance. So I asked why thought of stopping. His closest friend, who was a chain smoker, recently died of a lung cancer. He has neglected the chronic cough. So Mr. Pereira has thought of stopping. So what are the bad effects Mr. Pereira had? Mr. Pereira had some ideas about bad effects of smoking, such as lung cancer and other health effects. But he didn't consider much about the economic aspect. And during the conversation, I showed him that he can save about 6 lakhs per year. And also he is harming his pregnant wife and kids by exposing them to passive smoking. Then inquiring more, has he tried quitting before? Yes, he has tried few times. Once after birth of his first child, his wife helped him. And now it seems she has given up after telling him so many times. He had quit for about 1 month during these short periods of quitting. But he couldn't resist the urge to have a cigarette one day. And thereafter, it was like he had some kind of binge smoking. Just after a relapse, he had a binge smoking. He was a bit irritable on first few days, getting angry easily during the quit period. So he had some withdrawal effects. And his wife helped a lot during that period. But the friends didn't help much. So actually, the original question asked, we have to ask every patient about tobacco use at every visit. But in this instance, I have acquired several other details by asking about the current smoking habits and the quit effects. Then I have to assess the willingness to quit. So a little bit of theory. According to DSM-5, tobacco use disorder has 11 features. If any two of the above are present within the last 12 months, we can categorize him as tobacco use disorder. Previously in DSM-4, it is called tobacco dependence. And there were only 8 features. The last three are new additions. Loss of control, persistent desire, craving, failure to fulfill major role obligations, and a great deal of time is spent obtaining continued use of substance despite social or interpersonal problems, and the substance use in situations where it is physically hazardous. Continued use despite physical or psychological consequences, and important activities are reduced or given up because of the use, tolerance, and withdrawal. So we could identify several of these features in Mr. Pereira's case. For example, he was using the substance in situations where it is physically hazardous. He's smoking inside his home. Then I have to assess about the dependence. The time dependence we assess in an easy way by considering three factors: time for the first cigarette after waking, and number of cigarettes per day. So this, according to this, Mr. Pereira belongs to group D because he smokes his first cigarette within 30 minutes of waking, and he is smoking more than 10 cigarettes per day. Actually, this categorization is useful in the management of patients. We will see it later. Then we have to assess health of Mr. Pereira. Any smoking related health issues, red flags, ischemic heart disease, chest pain on exertion, shortness of breath, chronic cough, hemoptysis, any genitourinary symptoms, any other comorbidities, cardiovascular risk assessment. If he has not done any investigations, we have to plan fasting blood sugar, lipid profile, and ECG, or any other necessary investigations as opportunistic screening. And also we have to consider about the health of wife and children, pregnant wife, and he didn't have any children with asthma or chronic cough. So financial status also we have to assess, current financial status and the expenses for smoking. And we have to assess the relationship, any erectile dysfunction, relationship with the wife, relationship with the children, and social relationships with the friends and clients. They may be a barrier to smoking cessation. And we have to assess the support available. Wife has supported well in previous attempts, but now she may be given up. So we may have to give another appointment to meet Mr. Pereira with his wife and have a family counseling. And relatives, he said there's no support, and friends, very less support. And the barriers to quit, according to the Mr. Pereira's history, his withdrawal symptoms, urges, and peer pressure are barriers to quit in his case. And advice, we have to advise personalized, strong advice that is mentioned in the guideline, but not in a confrontational way. So when advising a patient, we have to consider his stage of change. Actually, in the assessment part, we have to assess to which part, stage he belongs to. This is called trans-theoretical or stages of change model. When a person is not considered of quitting, a person who is believing that he should not quit, we call him is in pre-contemplation stage. And when he is willing to quit, it is called contemplation. And then when the patient comes to see a healthcare professional or seeks help to quit, and maybe he is preparing his home, maybe preparing plans, that is called preparation. And when he starts quitting, we called it action. And when it is established, we call it maintenance. So when a person is maintaining his non-smoking habit for a longer period, maybe more than 6 months or 1 year, we can imagine that patient is permanently changed. But we have to keep in mind that anyone can go into relapse at any time. So the ways we counsel patients in different stages are different. We use a different approach to a person in pre-contemplation and another approach to a person in contemplation. So I think for this activity, I need your help. There are several attitudes, myths, and barriers to quit. And can you help as in a friendly discussion? If a patient says, I can quit anytime and I am not addicted. So how can we counsel such a patient? This is like a patient in pre-contemplation. What are your suggestions? Hello?
We can arrange a set target date of quitting.
Yes. We can ask about target date, yes. Yes, we can plan. If he says, I can quit anytime and I am not addicted. One way is asking about a quit date. And another way is ask about previous attempt to quit and the success rates. When we consider this evidence-based approach, this approach is like a little bit confrontational, but the one suggested is better, I think. So another myth or barrier to quit is a patient telling there is no need of support, advice, assistant, or help. In that case, how can we counsel such a patient?
Again, asking about previous attempts and showing him that he didn't have the support previously, but we are offering it now.
Yes, we can say support is, we can reframe support and explain that some withdrawal symptoms can be reduced by treatment.
And one of
We
the
can
important things that I mention in such situation is that is it is okay to fail a quitting attempt. Many people fail several times in quitting their attempts to quit smoking before they actually succeed. So you might have to go through this cycle several times.
yes.
So that would be a little gentle way to say that you value what he's trying to do, but it is okay if you don't succeed this time. There is always another time. You can try it again.
Yes.
So that way it is motivational, very supportive, and you are feeling empathy also that he might be scared. He's trying to give up something he thinks he's enjoying. So it is important to say that it is okay to fail. We can always try again. Okay, Prabhath.
Yes. And we can say that unsupported quit rate is 3 to 5%, but substantially higher with assistance. it's not a weakness to seek for assistance, but it will help you actually. And another myth is a patient telling, I am too addicted and it's too hard to quit. This may be a person, as Madam said, this may be a person who is tried and relapsed several times. As Madam said, in such a patient, we can say it's normal to have relapses. We also can explore pharmacotherapy used and offer options. Okay. Another myth is it's too late to quit, especially elderly patients. I might not benefit, so why bother? I have smoked for this much of years, so anyway, we have to die. Some people tell like that. How can we counsel such a patient? We can tell that benefits accumulate at all ages. And it's greater, it's true that it's greater if cessation achieved earlier, but still, even quitting later has several benefits. Another myth is my health has not been affected by smoking. You have to die of something, and I know someone who smoked heavily and lived a long time. And we can state that 1 in 2 people who continue to smoke after middle age will die prematurely or smoking related disease. We can reframe, for example, pictures like this, a smoker's lung and non-smoker's lung. We can show him that there is always smoking affecting the health of us. No point trying unless you want to quit successfully. We really have to need to quit. In this kind of patients, we have to explore for motivation and confidence. And we can give him other options like Quitline and drugs. I will explain what Quitline is. And cigarette helps me relax. We can suggest that other relaxation strategies, such as breathing techniques and progressive muscle relaxation. It's actually people who are smoking, when they reflect back, they will understand that it's not cigarettes help them relax, but absence of cigarettes make them stressed. So non-smokers are always relaxed. Cigarette smoking, chronic smokers, when they smoke a cigarette, they comes to baseline. Without a cigarette, they go down and they are stressed. We can show them that that's actually happening. This is one of the concerns, not very common in Sri Lanka, but it's proven that smoking cessation, there is weight gain of 2 to 4 kilos. About 10% of people have some weight gain, substantial weight gain more than 4 kilos. Still, the exercise and diet plans can be done at the same time. So it's not a reason to smoke and stay slim.
Excuse me, Prabhath. Is it due to sweets craving? When they quit smoking, they are craving for sweets, right?
Yeah,
Maybe is it the
maybe
reason for the
yeah, that may be
then
the
we can
reason, but
give the
it was proven that there is some weight gain after smoking cessation. I couldn't find the exact cause. Maybe possible, it's possible. There's craving for sweets because they start to feel tastes after about 1 to 2 days of stopping smoking.
can't we give nicotine lozenges to prevent it?
Yes, I will discuss about the drug therapy, nicotine replacement therapy. But it doesn't, the evidence doesn't say that nicotine replacement therapy reduces the weight gain, because usually nicotine replacement therapy is not for lifelong. We just we have to stop it also, no? And also we can mention that benefits of quitting smoking very much exceeds the effects of weight gain. Now we will discuss about how we assist Mr. Pereira and any patient who is coming for the smoking cessation. So according to guidelines, drugs are indicated for nicotine dependent people and who have previously experienced quit attempts unsuccessful. And if the patient is willing to use drugs for smoking cessation, we can offer them drugs. Nicotine dependence, as I said earlier, we can assess easily by asking him about smoking habit, whether he is having his first cigarette within 30 minutes of waking, and also he smoking more than 10 cigarettes per day. So in the absence of contraindications, pharmacotherapy is an effective aid when accompanied by behavioral support, and should be offered to all people who have evidence of nicotine dependence. Should be offered, and they can refuse. So the pharmacotherapy, there are 4 types of drugs available in the world: nicotine replacement therapy, varenicline, bupropion, and nortriptyline. But most of these are not available in Sri Lanka. Previously, long-acting patch was available in before COVID period, but it's not available now. Nicotine patch is a 21 milligram patch, that is a long-acting one that acts for 24 hours. There are short-acting nicotine replacement things like nicotine gums, lozenges, and sprays. Gums, they have 2 milligram and 4 milligram gums available in Sri Lanka. 2 milligram 12 gums, 1,300 rupees, and 4 milligram 12 gums, 1,400. Varenicline is not available. And bupropion, there is a slow release brand, 150 milligram. It's about 50 rupees per tablet. And nortriptyline is, I will discuss about nortriptyline in the later slides. It's not much used and not much prescribed in worldwide for the smoking cessation, though it can be used. So this is a research done in New Zealand government. We can see they have tried several methods, compared the success rates with placebo control and active treatment. Varenicline with support, nortriptyline with support, bupropion with support, NRT with support, and behavioral interventions alone. So here we can see that maximum benefit occurs with varenicline with support. So this is a very small, this is a small study done in New Zealand, but usually worldwide data also reflect this kind of context. Nicotine replacement therapy. We can start nicotine replacement on the quit date. In most of the countries, it's a over-the-counter drug. We can buy nicotine replacement from pharmacy. Combination with long-acting and short-acting nicotine replacement has shown higher efficacy in long-term cessation when compared to monotherapy alone. Combination nicotine replacement is recommended as first-line treatment for nicotine-dependent smokers. Now, the combination NRT means long-acting plus short-acting nicotine replacement. Long-acting is the patch that lasts for 24 hours. Short-acting is the gums or lozenges or something like that. And also, combination is recommended for those who are unable to quit with monotherapy and who experience cravings with monotherapy. The combination NRT means long-acting patch daily plus 2 mg or 4 mg gum as needed. Patient can take up to hourly, 2 mg or 4 mg gum hourly. So this is the simple graph 2x2 table I previously discussed. Time to first cigarette after waking and number of cigarettes per day. So a person who smokes less than 10 cigarettes and who smokes more than 30 minutes after waking, that is the least dependent person. Those kind of people can be prescribed monotherapy. Nicotine 2 mg or 4 mg lozenges or gums. A person who is either smokes more than 10 per day, but smokes more than 30 minutes after waking, or someone who smokes less than 10 cigarettes per day, but smokes early in the morning. They are the middle group, group B and C. They can be given a long-acting combination therapy, long-acting nicotine patch with the 2 mg gum for a severely dependent person who smokes more than 10 per day and smokes within 30 minutes of waking. We can give a high dose combination, 21 mg patch plus 4 mg gum or 4 mg lozenge. So this guideline is from Australian guidelines. NICE guidelines doesn't give this kind of very structured and informative guideline, but they just guide our therapy. So this is an easy way to keep in mind what we have learned and the available things, available nicotine replacement. So how to stop nicotine replacement? There is no evidence to support tapering or reducing the nicotine replacement. We can give nicotine replacement for adequate duration. Withdrawal effects last for 2 weeks without nicotine replacement. We can ask patient to stop it according to his will. Usually, nicotine replacement therapy courses are for 8 to 12 weeks. More than that, there were 2 randomized controlled trials done, and there was no excessive benefit in longer use. So clinician may consider recommending prolonged nicotine replacement therapy for relapse prevention, but short-acting nicotine replacement is over the counter. Patient can take it whenever he wants. So he doesn't need a prescription. But we can plan his quit attempt. So we can make him agree to the fact that he has to stop nicotine replacement sometime during his quit plan. The next drug we discuss is the varenicline. It's a nicotinic receptor partial agonist. Partial agonist means the main active ingredient in smoking is nicotine. So nicotine binds to nicotinic receptor of acetylcholine as an agonist. Now, varenicline has a higher affinity to this nicotinic acetylcholine receptor, but it doesn't stimulate the receptor as strongly as the nicotine. So that's why it's called a partial agonist. So varenicline binds to nicotine receptor and gives some effect. So when patient is not smoking, he gets some effect with varenicline. But when patient is smoking, it prevents the pleasure response. So patient will not feel the same effect of smoking as before. Many trials show that varenicline is superior to bupropion as well as nicotine replacement in inducing prolonged cessation. It should be started 1 week prior to the proposed quit date and should be used with caution for those having depression or risk of self-harm. Nausea, headache, insomnia, and abnormal dreams are the commonest side effects. And usually, treatment is for 12 weeks. This is an example quit plan example of varenicline use. We can start 7 days before and gradually increase the dose and then maintain it till 12 weeks. And in the follow-up, usually nicotine replacement or varenicline or bupropion, we don't give prescriptions for more than 2 weeks after the quit dates. So every 2 weekly, we have to renew the prescription after reassessing the patient and reviewing the progress. We can assess the side effects like nausea, abnormal dreams, and also we have to assess about the depression and suicidal thought. And then we have to renew the prescription. And at the completion of 12 weeks, we can review and consider further 12-week treatment to reduce relapse. Actually, this should be done. Varenicline should be prescribed by a specialist, not in the primary care. So this, but primary care physicians can continue varenicline after starting. So at 12 weeks, we have to refer to the specialist and get his opinion regarding the continuation. Then bupropion also should be started by a specialist. It's a norepinephrine and dopamine reuptake inhibitor. Also, it has a nicotinic antagonist action. That is what we use for smoking cessation. Bupropion is an antidepressant originally, and it reduces the urge to smoke as well as reduces symptoms of withdrawal. It is usually started 1 to 2 weeks before the set quit date and continued for 7 to 12 weeks. It's preferable in patients with chronic diseases or depression, but contraindicated in past history of seizures and also monoamine oxidase inhibitor concomitant use, as well as in pregnancy and breastfeeding. It should be used with caution with drugs that lower seizure threshold. So bupropion, this is one of the dosing regimes. Since it is available in Sri Lanka SR form, we have to start the bupropion 150 milligram daily 1 to 2 weeks before. to reach the maximum therapeutic concentration by the date of quitting, and continue same dose for 3 more days after quit date, and then increase to twice daily regime. And this should be continued for 7 to 12 weeks. And then as primary care physicians, we can give prescriptions, renew the prescriptions for bupropion, but at 7 weeks, we have to refer for the specialist to review the need for a prolonged prescription. And after 12 weeks, we can arrange follow-up visits to primary care in any time in a relapse. The fourth drug is nortriptyline. It is not much used. It's a tricyclic antidepressant like amitriptyline. Very small number of trials have proven there is some efficacy in it in smoking cessation, but potential side effects are more, like dry mouth, constipation, nausea, sedation, and headaches, as well as cardiac arrhythmias. And it is a drug with very low safety profile because overdose can cause arrhythmias. That's why it's not much used. And other supportive treatment like anxiolytics, because in the first few weeks, patient will experience anxiety. There was a Cochrane review done in 2000. There is no consistent evidence to support that anxiolytics aid in smoking cessation, but the available evidence does not rule out a possible effect. So we can prescribe anxiolytic during the first few weeks of smoking cessation to the patient who is having withdrawal symptoms. Now about the guidelines. NICE guidelines recommend to offer nicotine replacement therapy or varenicline or bupropion as appropriate. Should normally be prescribed as part of a quit plan with target quit date. And prescription should not exceed 2 weeks after quit date. Maximum for bupropion and varenicline is 3 to 4 weeks. That is the first prescription, thereafter 2 weekly. Repeat prescriptions are given only for those who are successful. And if a relapse occurs, very important, there should be at least a 6-month gap before the next prescription. Unless special unavoidable circumstances have hampered the initial attempt, we have to wait for 6 months to plan another quit attempt with drugs. Nicotine replacement can be given to following groups after explaining risks and benefits, including young people 12 to 17 years of age, pregnant women, breastfeeding women, as well as people with unstable cardiac conditions. But varenicline or bupropion should not be offered to age less than 18 years, pregnant or breastfeeding. And varenicline or bupropion may be offered to people with unstable cardiac disorders, subject to clinical judgment by a specialist. And very importantly, NICE doesn't recommend nicotine replacement, varenicline or bupropion in any combination. Consider offering combination of nicotine replacement, that is long-acting and short-acting nicotine replacement, to people who show high level of dependence and who have found single monotherapy of nicotine replacement inadequate. So clinicians should not favor one medication over the other unless for clinical indications according to NICE guidelines. According to NICE, varenicline, bupropion, and nicotine replacement are equal. This is the 2021 update. But other guidelines slightly differ. For example, United States Preventive Task Force guidelines clearly mention that varenicline is superior to bupropion and nicotine replacement. And Australian guidelines also tell that varenicline plus combination NRT has the highest success rate. So that's what they promote. And the JNCCN, that is a cancer guideline, a smoking cessation guideline for cancer patients. They also say varenicline and combination NRT is superior. Also, American College of Cardiologists also suggest the same. The problem and this conflict may be because these evidence are tampered with, because there are so many researchers done in smoking cessation are funded by tobacco companies. They are and that's happening, and there are a lot of I mean affiliations and that kind of interferences to the data. That's why NICE is very slow to accept this new evidence. So the behavioral interventions, NICE recommends very brief advice, cognitive behavioral therapy, motivational interviewing, group therapy, as well as this group seminar thing. This is a book written by someone called Alan Carr, and it's a guide for group therapy. So these are the things recommended by NICE. And other guidelines also suggest telephone counseling as well as text message based interventions to induce quit, help people quit. Then we have to arrange a quit plan. In our quit plan, we have to educate the patient regarding the timeline of benefits. Within 20 minutes, patient's heart rate and blood pressure drop. And within 12 hours, patient's carbon monoxide level drops. Within 2 to 12 weeks, circulation improves. And within 1 to 9 months, shortness of breath, lung, cough improves. Coronary heart disease is half that of a smokers in 1 year. So like that, there are a lot of evidence of benefits. So the nicotine withdrawal, DSM-5 describes tobacco withdrawal as daily use of at least several weeks, followed by abrupt cessation, leading to 4 or more of the following 7 signs: irritability, anxiety, difficulty concentrating, increased appetite, restlessness, depressed mood, and insomnia. I think Dr. Finas, this increased appetite, which is withdrawal symptoms, this also may be contributing to weight gain of cessation.
Prabhath, can I interrupt you for a second?
Yes.
Because Finas asked, I thought I'll comment. The link between smoking and the food intake is a well-known link that has been established, but there are a lot of unknown areas. So when you take smoking, the main substance is nicotine, and it acts through dopamine pathways. So once a person starts smoking, they develop more and more nicotine receptors in the body. So this nicotine is considered an appetite suppressant. So that's why smoking is linked with reduced weight reduction. So by any way, it is not a method that we can endorse, that you can smoke to reduce weight, because the harm you get from smoking is much, much more than the weight you are trying to reduce. So it should never be promoted. The appetite suppression is removed when you stop smoking, when the nicotine receptors don't get their substrate. And that is how the appetite increases, and then there is the increase, the insulin secretion, and the need for eating, the binge becomes prominent in patients who are withdrawing. There is another theory that after smoking, the gut flora also alters and increases certain chemicals in our GI tract to influence the appetite. So those are some of the theories, but nothing is kind of solidly proven, right? Okay.
Thank you, madam.
Thank you, madam. And so how to minimize these withdrawal effects? Sorry. We can advise the patient to drink more and more water, eat fruits and vegetables, focus on a hobby, exercise, relaxation, go to sleep and wake up on a regular time, and carry some sugar-free chewing gums, and to avoid high-calorie foods and beverages. These are few advices we can give, and also we can ask him to acquire support. Tell his wife, a friend or relative about quit plan and ask them to support. During the withdrawal symptoms, patient may be irritable, so wife may be having to bear irritable behavior, and emotionally support and encourage the good achievements. And also to prevent barriers. For example, he suggested when a friend call to have a cigarette in a group, have one friend who knows about your quit plan, so he will speak for you. Don't give him a cigarette, he is in a quit plan, like that. Or he may ask some other thing for you to do, and avoid that cigarette. And if things go uncontrollable with peer pressure, person can inform his wife, or she will give a call about a family emergency or something like that. He can avoid that kind of situations. And if he fails to buy cigarettes in the usual grocery shop, he can avoid it by going in a different pathway to home or like that. And also there are coupled habits. Some people smoke with the tea. Some people smoke while drinking alcohol. So we have to discuss alternatives for this during our quit plan. We have to advise the person to get rid of cigarettes, matches, lighters, ashtrays, any other objects that are triggers for smoking using other tobacco products. And also situations. Avoid people who use tobacco. Establish friendships with people who don't use tobacco, and avoid smoke breaks and social situations. And also places. Avoid places where you usually buy tobacco products, and avoid locations where you usually use the tobacco, and also take a different route to avoid the place, such place. So these are the options we can give to discuss the barriers, avoid the barriers. And there are several external support. ADDIC, or Alcohol and Drug Information Center, is based in Colombo, and there are several branches in island-wide, and can book an appointment via website. And also there is a University of Colombo, there are two centers. One is called Center for Combating Tobacco and Tobacco Unmasked. These are global movements, and our centers are in University of Colombo, and they have a very updated websites, and also about the information. And then National Authority on Tobacco and Alcohol, also called NATA. It has a national quit helpline. The number is hotline number is 1948 I just tried to call it few times, but I couldn't. It's always busy. I don't know whether several people call it, but it's busy. Then National Dangerous Drug Control Board also act to make regulations regarding the tobacco. And for smartphone users, we can introduce this WHO Quit Tobacco app. We can make a quit plan. There are 4 steps. Step 1, select a quit date. Then step 2, write down who you would like to have support you with the decision to quit. So this app sends an email to that person, and then identify personal challenges that will make it difficult and the coping strategies they have to write down, and write down the steps you will take to make your environment tobacco free, like removing ashtrays, removing empty cigarette packets, etc. And then in the quit plan, make a list of your reasons to quit tobacco use. Then they will display the progress with the benefits, personal quit plan, motivation, everything. And special groups, smoking in pregnancy. All pregnant women should be tested for smoking using carbon monoxide detectors. This is a recommendation in UK. Nice guideline, because compared to Sri Lanka, Western countries, more females smoke. And all pregnant women who have smoked within last 2 weeks, or who have stopped smoking within last 2 weeks, or having a carbon monoxide level higher than a cutoff range, should be referred to stop smoking services. So the reason for this carbon monoxide breath test is the smoking pregnant women have a difficulty to come out that they have this habit, because they are under social pressure. That's why the carbon monoxide test is offered to them. So the pregnant women, the first line treatment is cognitive behavioral therapy, motivational interweaving, and structured self-help, that is behavioral interventions. If first line interventions fail, they can be offered nicotine replacement. There is no evidence that nicotine replacement therapy affects birth weight of the child, but we don't know about the harmful effects, especially in the first trimester. And we have to advise pregnant mothers to remove nicotine replacement patches at night. During pregnancy, as well as breastfeeding, bupropion and varenicline are contraindicated. So basically, that covers the guideline-based management, but I have to add few information we have to know about. There are several vaping devices. These are common in Sri Lanka also. In the schools, I think I had a story that one child has brought a vaping device to school and charged some 100 rupees or something for a puff. He has used it as a income from his friends. Vaping device is a electronic device where there is a cartridge containing nicotine liquid, and it produces vapor, and that's why it's called vaping device. And they are available in several very nice forms, like maybe highlighters, pens, key tags. There are several things, and they can be charged with these phone chargers. And these are called heated tobacco products. And NICE recommends some heated tobacco products can be used as nicotine replacement therapy. But in Sri Lanka, we have Chinese things. So they are not recommended because we don't know the amount of nicotine present in the vapor. It can be different and maybe even more than a normal smoke cigarette. So Cochrane review says no studies reported heated tobacco products for smoking cessation and reducing smoking. In UK, there is a agency called MHRA which regulates these heated tobacco products. So MHRA accreditation is needed for vaping devices. But Sri Lanka, there are no such regulations. So there is moderate certainty evidence that smokers switching to heated vaping devices have a lower exposure. But in some studies, there is moderate to low certainty evidence that there is higher exposure also. Because of this conflict of evidence, heated tobacco products, so vaping devices are not recommended. In addition, there is building up evidence that they promote smoking among non-smokers, especially school-going children. And there is another thing called smokeless tobacco. In UK, these are used like not burned, but kept in mouth or chewed. These are the UK products. In Sri Lanka, I don't know. We can say beetle chewing, the tobacco used for beetle chewing also can be considered as smokeless tobacco.
Yes, it can be considered. And you
Yes.
should always, if patients say, if they are not smoking, the next question you should be asking is, are you using any other tobacco containing product? Like now Prabhath very comprehensively described, there are a lot of tobacco containing products in the market that are not smoking, like cigarettes or cigars. And the most very fashionable thing and the trendy thing that is going on now is the vaping device. But also even in the from olden days, certain cultural aspects, smoking was considered to be kind of a higher social thing. It was considered as a symbol of prosperity. But now people are kind of have developed a negative attitude towards smoking, which is very good. But still, the people who are selling these products are coming up with novel ideas and innovative creations to promote the same product in various ways. Now, the recent pre-COVID era, when cigarette smoking was very high, the availability went down during COVID. And most of the people who used to smoke cigarettes came down to smoking BD. So in our country, the proportion of BD smokers increased. And now with the economic crisis, the price of a cigar has gone up, almost double since pre-COVID, or maybe more. So what the companies have come up with is that they have reduced the size of the cigar and they are selling it to a price of 100 rupees. So the person who is using it is arguing between the size and the amount he is spending, and he is settling to something that is he is able to compromise. So our attempts are also fight against the changing market also. It is important that as primary care physicians, we always keep up with these new products, how they work, and what changes have come to the market, because patients come and ask us. So I hope this presentation will motivate you to read more on all those products also. Okay, Prabhath.
Yeah. When we consider the trends, the smoking trend is reducing. rate of smoking is reducing. From 2000 to 2020 in Sri Lanka, it has reduced by about 6%. There are new government policies also. For example, in 1990s, there were 5.2 billion cigarette stick production per year, whereas now it has reduced to 4 billion per year. And also there is a law to stop smoking at public places, and there are pictorial warnings that should cover 80% of the cigarette packs. Cigarette tax is about 60%. So when you buy a cigarette for 125 rupees, about 70 rupees is for the government. And one of the that means it is one of the significant contributors to the gross domestic product of Sri Lanka. And also now cigarette companies cannot advertise. But there are several ways they promote smoking. For example, in kids, they use various cartoon characters. And in 1970s, 80s, there were several cinema stars smoking in the movies, and also smoking in the school uniform in front of schools as a promotional activity. These kind of things are reported in Sri Lanka. So also I have to add that in 2024, World No Tobacco Day is we are going to celebrate it on 31st of May. And the theme is protecting children from tobacco industry interference. So these are the references I used. And I would like to thank Madam Malkanti Galhena, our consultant at BH Panadura, as well as Dr. Prasanna Das, acting consultant family physician, who guided me in doing this presentation, for all the support, advice, assistance, guidance, as well as help. Thank you very much, madam.
Thank you very much, Prabhath. I think you have captured all what we have discussed, and you did a very comprehensive presentation. It's almost 11 o'clock now. Does anyone have any questions or comments to make? Your personal experience with patients who have tried to quit smoking, anything? Can you go to the beginning of the clinical presentation, Prabhath?
Yes, ma'am.
The introduction. No, after that. No, the next one. No, the one before, I think. The one, yeah. Here, now, this is the structure for an OSCE, Prabhath had mentioned in 10 minutes. So, greeting, building up a rapport and empathy and motivate. So this patient whom Prabhath presented has already entered the contemplation state and come. So he has come to talk to you about a bad habit of his, and he's asking for help. So showing empathy is very, very important, and motivating is very important. So our tone, the way we talk, our body language should be very gentle, non-threatening and not non-accusing also. We should let him talk, and we should always tell him that it is not easy to someone to come forward and talk about a bad habit, and he has taken his first step. So that is a very, very huge move in quitting smoking. So you have to congratulate him for taking his first move. So in the ask section, as Prabhath mentioned, you have to ask all about smoking, how he started, how it evolved over the years, what type of smoking types he have used, and co-substance use, any attempts to quit, whether there were hospital admissions, everything you need to ask. And it's also important to ask about his childhood, where he got the influence or the motivation to start smoking, because it's shown that if fathers smoke, the children also have a higher risks to go into the same habit, and if not like the father, they will be a heavier smokers than their fathers. So that influence you can ask. In the assessment, you assess the impact, like how Prabhath did. You assess the impact on the health, on the finance, and on the relationships. All three are important. When you ask for finance, you have to ask about how it's affecting his job and how much he is spending, because it is known that about 5 to 15% of your disposable income is spent on smoking in most of these people. So likewise, you have to calculate it and show it in numbers. That will be a very, very motivating factor for them to kind of continue their attempt to quit smoking. If you ask them, people who are smoking, what is the only thing that you don't like about smoking? They will say most of the time that it costs them a lot. So that you can pick it up as a cue to start your motivational process. And then to again, another very sensitive area to start motivating people who are in the pre-contemplation state is the harm they are causing not only to themselves, but their loved ones, especially the children. If you take time to explain those to them, they become very sensitive and they kind of listen. It might not happen in one consultation. It may need several follow-up consultations to have one small successful step forward. So coming to advice, you have to, like the picture that Prabhath showed towards the end of his presentation. What happens if you stop smoking? From the first 20 minutes you stop smoking, you start getting benefits. And that benefit adds up until about 10, 15, 20 years forwards. But if you don't stop smoking, these are the things that are going to happen. So taking in these facts into consideration, as your doctor, I strongly advise you to stop smoking. And I can surely be helpful to stop smoking. That is how you give very personal advice to stop smoking. And you always have to say, quitting or say coming down in your habit, reducing the quantity you smoke when you fall ill is not sufficient. It's not going to help you long term, because people do that. And then the other thing is, there are social smokers. They say, I only smoke when I go to a party or I get together with my friends. So even occasional social smokes are harmful. You have to be very clear and thorough in convincing those messages. So after telling those, you say, I advise you to strongly stop smoking altogether. Then when you come to assist, there are the pharmacological methods and non-pharmacological methods. Prabhath described the pharmacological methods very comprehensively. It's true that for your exam purposes, we go through NICE guidelines. So you will have to stick to NICE guidelines. But we also, for our interest sake, we read other guidelines and we see what is different. And now I usually prefer to mention that combination therapy is superior to using nicotine replacement therapy. But remember, for your exam purposes, you need to stick with NICE guidelines. In the assisting part, non-pharmacological behavioral things, I think, Prabhath, you could have mentioned the sipping of cold drinks, sour drinks during the time you are craving. The craving will last for a few minutes or an hour or two. If you do such things, the craving will die down gradually. You just need to hold on to that little bit of time. And assisting, there is a mnemonic called STAR, S-T-A-R. S is for setting time. T is to tell all your family and friends and that you are going to quit and that you are going to need support from them. A is anticipate problems. It's not going to be a smooth sail when you start to try quitting smoking. You are going to go through ups and downs. You're going to have mood swings. You're going to have problems with other people. So it's going to be a difficult time, and you be mentally prepared and anticipate that you're going to get into problems. And the last letter R comes, like Prabhath said, to remove all tobacco-related substances from your environment. That includes the cigarette packs, the buds, the ashtrays, if you are using a lighter, anything that will kind of cause you to get a urge to smoke. All that can be needs to be removed before you enter starting date. So those are the little things I just wanted to summarize. This is a very good presentation. I hope all of you will take time and go through the recording later on. It will help you immensely with your skis. And thank you very much, Prabhath, for all the time you have spent on putting up this together. And I think we can wrap it up tonight, isn't it?
Yes, madam. There was one question.
Yes.
How long the withdrawal symptoms will be lasted once person quits smoke?
Generally, the thing is, certain people will have withdrawal symptoms, certain people will not have withdrawal symptoms. Those who have, generally they tend to have very bad ones up to about 5-6 days, but it can go up to 2 to 4 weeks time. That is what the guidelines say. So that if you can get over that period, you are safe. But having said that, if you come across a patient who had quit smoking, and you have mentioned it in your initial history taking that he used to smoke and he quit 5 years back or so on. In the follow-up consultations, just don't forget to just tap on that and ask, are you still abstaining from smoking? Because at the initial stage, when you quit smoking, your morale is high, you have achieved something very difficult, so you tend to stick to quit smoking. But as time passes by, your motivation weans off, and sometimes certain triggers can make you go back into that habit. So just because in the initial consultation somebody has written stop smoking, don't forget to just go back and probe that area in the follow-up consultations as well, right? Okay. Did I answer the question?
Yes, madam. Yes. Thank you very much.
Okay. Okay, then. Shall we finish it?
Yes, madam. Yes.
Oh.
Good.
Right. Thank you very much. Good night.